Okay, so I will explain the data study entitled BRAF 600E mutation in papillary thyroid cancer and its effect of postoperative radioiodine therapy. So we modify our therapeutic strategy. So first of all, we don't have any conflict of interest. And the mutation of BRAF V600E gene is the most frequent genetic alteration in papillary thyroid cancer, with an incidence that goes from 23 to 83%. The role of this mutation as a prognostic marker in the staging of molecular risk for thyroid cancer is promising. In addition, it has been associated with more aggressive clinical pathological characteristics, increased recurrence, resistance to radioiodine in metastatic disease, and even mortality. However, in the latest tape update, the American Thyroid Association recognizes its role as a marker for the risk of recurrence, but not recommending the routine study of the mutation. This mutation involves the substitution of valine for glutamate in position 600 of the BRAF protein. It has been associated with the reduced uptake of radioiodine due in part to the activation of the protein kinase signaling pathway activated by mitogens. This signaling pathway is essential for the homeostasis of the thyroid cell, and the activation of the MAC pathway induce abnormal growth and resistance to pro-apoptotic signals. The molecular bases that explain the relationships between the various components are complex and controversial, but with clinical relevance because they are related to the differentiation and resistance to radioiodine. This resistance is mediated by BRAF by stimulating the induction of tumor growth factor secretion, which repress the expression of sodium iodine importer that is necessary for the uptake of iodine in the cell. This loss of expression is the basis of refractoriness to treatment with radioiodine. As a consequence, in mutated papillary thyroid cancer, the more aggressive surgery will be the best therapeutic option for this group of these patients. In this context, most studies measure this resistance in metastatic cancers, but the assessment of the response is obtained with thyroglobulin serum values, and there are no studies in the literature that quantify the effect of the mutation in the imaging of time-varied CT or SPECT-CT. However, there are other methods to estimate the quantification of the response to treatment, such as dosimetry. Through this methodology, important variables like absorptors can be obtained, a parameter related to cell destruction and to the effect of the treatment. A detailed measurement of the absorption of radioiodine and the behavior of the BRAF mutation after postoperative treatment will definitely establish the prognostic value of the mutation and change the therapeutic strategy. So our objectives were the following: to describe the characteristics of patients with papillary thyroid cancer according to their mutational status, to quantify the response of radioiodine administered after surgery, and to obtain a predictive model of risk stratification that defines patients with a higher risk of resistance to radioiodine. So we carry out a prospective analytical observational cohort study. The study population was patients with papillary thyroid carcinoma treated with surgery and postoperative radioiodine from September 2025 to January 2017. The inclusion criteria were histological diagnosis of papillary thyroid cancer, surgical treatment with total thyroidectomy, postoperative radioiodine treatment. The exclusion criteria were incidental cancer, relapse to papillary thyroid cancer, previously received therapy with radioiodine, and surgery at another medical center or by another surgical team. The following variables were studied: demographics, surgical technique, tumor staging after study of the surgical specimen, pathological features, number of affected lymph nodes, histological type, desmoplastic reaction, bilateral decide, extrathyroid extension, and multiple focus. Patients were classified according to the risk of recurrence as low, intermediate, or high rise, following the recommendation of the ATA guidelines, so that they were treated with dose of 30, 100, or 150 millicuries of radioiodine after stimulation of recombinant DSH. To quantify the response of radioiodine after surgery, we studied the SPECT-CT imaging of postoperative thyroid remnants for each patient both 2 and 7 days after radioiodine treatment. After 2 days, the uptake of the remnants in the surgical bed had values close to their maximum value, while after 7 days, the activity of radioiodine was smaller. The analysis of the SPECT-CT images in the workstation involved the identification of the thyroid remnants and the differentiation of the physiological accumulation of the radioiodine in other anatomical areas, as shown in this imaging. For the quantification of the activity of the thyroid remnants, previously a calibration factor was applied according to the recently published recommendations. Using dosimetry, the following variables were analyzed: absorbed dose per administered activity, percentage of activity at the 2 and 7 days per unit mass, radioiodine effective half-life. The calculation of dosimetric variables was made by adjusting the dose of radioiodine and the mass of the remnants, which was previously calculated. Thus, we eliminate the influence of the dose of radioiodine and the volume of the remnants. To this end, we use the formulas obtained for a medical dose of internal radiation. The serum values of thyroglobulin and anti-thyroglobulin antibodies were measured prior to the administration of radioiodine, 2 days after treatment and 6 months after treatment. So as we can see in this table, these were our results. Out of the 41 patients treated surgically for papillary thyroid cancer who were administered radioiodine treatment, 61% were positive for the mutation. The frequency of the mutation in women was somewhat higher than in men, but it's not significant. Mean patient age was 52 years old. There were a total of 75% patients with bilateral prophylactic central lymph node dissection. Of these, 51% were BRAF positive. In 16% therapeutic lymph node dissection was performed due to lymph node metastasis, and all of them were BRAF positive. There was no difference between BRAF positive or negative to decide the sentinel lymph node technique. The number of affected lymph nodes was significantly higher in BRAF positive patients at 3 versus 1. The mutation was higher in patients with the classic type, with a total of 11 cases compared to follicular mix. Regarding to the tumor states after the pathological analysis of the surgical specimen, 80% of the patients who were in a more advanced stage, 3 and 4, were BRAF positive. More than a half of patients who were in the earliest stage, 1 and 2, did not have the mutation. In the BRAF positive group, 85% had a desmoplastic reaction. There were no difference between the two groups in terms of extrathyroid extension, bilaterality, or presence of more than one carcinoma site. These SPECT-CT images represent an example for activity after administration of the radioiodine dose. The first imaging shows a patient without the mutation at 2 and 7 days after radioiodine iodine treatment. And the second imaging shows a patient without the mutation. We can be seen that the patient with the mutation has a lower uptake, which will be quantified with the method that I have explained previously. So iodine biokinetics were studied in a total of 67 thyroid remnant, because even though the majority of patients had a single thyroid remnant, there were cases of 2 and even 3 remnants in the same patients. As we can see in this graphic, the BRAF positive patients had a lower absorbed dose per administered activity, lower percentage of activity per unit mass and per administered activity at 2 days, lower activity per unit mass administered activity at 7 days. Although there were no significant difference and lower half effective time was observed in the patients with the mutation. The difference between BRAF positive and negative in thyroglobulin values prior to iodine per iodine were 20 versus 7, and after 2 days is 17 versus 24 without significance. The change of pre-iodine after 2 days is significant in BRAF negative group, whereas the change of the pre-iodine after 2 days is not statistically significant in BRAF positive. After 6 months, there were no significant differences between 2 groups. This table shows, as we can see, the results from the bivariant analysis of the association of different characteristics of the dose absorbed, showing only those characteristics with a p-value less than 0.15. The variables that were found to be significantly associated with the absorbed dose were age and BRAF mutation. In case of the age, for each 1 year increase, the absorbed dose was almost 1 time greater as for the mutation. The dose absorbed in BRAF negative was more than 2 times than BRAF positive patients. In the multivariate analysis, only the mutation variable was significant. According with our results, the BRAF mutation of papillary thyroid cancer is the most frequent genetic alteration, as we can see in other papers. Furthermore, the patients undergoing therapeutic life node dissection, all of them were BRAF positives, evident of the aggressive nature of the mutation, as demonstrated in several studies. Likewise, the more advanced stage and the number of metastatic lymph nodes reinforce the worst prognosis of the mutation, as recently published. The most frequently histopathological type was classic, that is similar to other papers after the identification of the genome sequencing for papillary thyroid cancer. The desmoplastic reaction was also more frequent, as published in some studies. However, no difference has been found between other risk factors for recurrence, such as the thyroid extension, multiple foci, or bilateral, probably for the site of the sample. But this is the first study to evaluate the response of the mutation to treatment with the radioiodine in a quantitative manner by calculating parameters related to iodine biokinetics with the dosimetry. The absorbed radioiodine dose levels were significantly lower in patients BRAF positive, which correlates with experimental studies with inhibition of the symptoms secondary to the effect of the mutation. Likewise, the percentage of radioiodine activity after 2 and 7 days was lower in BRAF positive patients. A short radioiodine half-life was observed in patients with the mutation, although without statistical significance. For this, we believe that dosimetry can be an alternative to quantify and evaluate the effect of postoperative radioiodine treatment, and that is compatible with the recommendation in the initial guidelines for papillary thyroid cancer. With regards to serum thyroglobulin values, an increase was observed 2 days after the administration of radioiodine in patients without the mutation. However, this peak concentration was not observed in patients in BRAF positive. This increase has been identified in the literature related with increased destruction of the thyroid remnants. In this context, the lower concentration of serum thyroglobulin after treatment in patients BRAF positive is interpreted as a less cellular destruction and increased resistance to radioiodine. However, in the result at the 6 months of follow-up, this difference was not observed. So it's necessary to evaluate it with a longer term, with more number of patients to define the clinical consequence. We observed that the only variable that was significant in the multivariate analysis was, was the mutation. So it's a good prognostic marker to consider. However, we could not establish a predictive model to determine the profile of the patients with greater resistance to radioiodine therapy, probably because of the sample size. In contrast, we identify the patient's characteristics with risk of resistance to radioiodine, AIDS and BRAF mutation. In case of AIDS, as patients become older, radioiodine absorption increases. This fact is interest for future studies that measure the actual benefit of the radioiodine in older patients. One of limitation of the study is the sample size. In addition, the study is based on thyroid remnants, which may be remnants of both tumor and normal thyroid tissue. And therefore, the direct nature of the tumor process is not represented. However, more longer-term studies are needed with large sample size to confirm these results. In conclusion, the mutation of BRAF P600 gene is related to factors for a poor prognosis, such as more advanced stage or metastatic lymph nodes. BRAF positive patients show that the treatment with radioiodine is less efficient since the beginning of the disease, and the uptake of radioiodine is higher in older patients. So, thank you so much.